Hello, and thanks for listening to Healthcare 360, a podcast by Beth Israel Lahey Health. I'm Rob Fields, the Chief Clinical Officer here at Beth Israel Lahey, and I have the pleasure of talking to Dr. George King today. As a researcher and a longtime, really foundational leader in the world of diabetes internationally, but certainly at the Joslin Diabetes Center here in Boston. Thanks for joining us, Dr. King.
Well, thank you for having me, Rob. Glad to be here.
So if you don't mind telling us a little bit about yourself and your interests and a little bit about your path to get folks to know you a little bit.
Yes, so I've been here at Joslin Diabetes Center and I guess Harvard Medical School for over 44 years. So it's a long time since I finished training uh, as a researcher and endocrinologist at the National Institute of Health. So my interest has always been to be a physician taking care of people because I guess I've come from a long line of physicians in the family ever since from China. So I came here from Taiwan when I was about 10 years old.
Mhm.
And so I've always been interested in science. So I followed that sort of a line and went into very interesting basic biochemistry and then went to medical school as a really an investigative type, and then went to NIH's training and became an endocrinologist and diabetes because I find metabolic changes to be so exciting and so interesting. In addition, the disease of diabetes have always fascinated me because it affects so many organs, and so I will have a chance to really understand the general systemic effect. So as a then following that route, um, I developed a area of interest in the complications of diabetes
Yeah.
that is, what was causing diabetic people to have bad eye disease, kidney diseases, heart disease. So how can we prevent it? So that's where the research have led me for the last 30, 40 years. And our, I guess, claim to fame in that area is we were the, I guess, initiator and of the idea that certain growth factors called VEGF as a major cause of severe diabetic eye disease. So we're very proud that the treatment of that now have decreased the blindness
Right.
in people with diabetes from almost 40% when I first got here in 1980s to now at the best centers is only about 2 to 4%. So we're very proud of that. As we continue that line of research, but the second area of interest that developed really more recently, last 20 years, I guess, is that interest in diabetes in Asian Americans. Being Asian American myself, the impetus from that is actually personal because my father actually had diabetes, and
Mm.
when he was in the 70s, he called me up and said he just developed diabetes, and his doctor told him to, exercise more, eat better, and lose weight, the usual
Right.
recommendation. And he says, "Well, you're a big time Harvard professor. Tell me, well, what should I do? Because I'm on like insulin, I'm on oral agent. I really don't want to take these medications."
Yeah.
And he says, "How much weight should I lose?" I said, "Well, you really shouldn't lose any weight because my father at that time was 72 and his weight was 125 pounds
Oh my
and
gosh.
he's 5'6". And
Right.
so not very tall, but still, not much weight. I said,
Yeah.
absolutely do not lose any weight because that's, your BMI is 20. That doesn't make sense.
Right.
So that was the impetus. So I started looking into the fact, why does Asian American develop so much diabetes with such low body weight? And really, there wasn't any information. There was no real recommendations. All the recommendation was generic, and you essentially translated whatever is known to from English to that language. So I started to get a group of people around the country together and to look into this, and then got to fortunately have the CDC to agree to start including Asian Americans into a national study called NHANES,
Mhm.
because even though that's been going on since the 1960s, you never included Asians until 2011. So from there, we really got going to increase awareness that Asian American develop diabetes at low body weight, and the recommendation really have to be changed. So essentially, my work now is focused on research. I'm head of research at Joslin and professor of medicine and ophthalmology at Harvard. But the second part, I guess, more of as a volunteer, according to Joslin, that formally I'm not supposed to be doing this, but I, I am also leading the Asian diabetes effort locally, and
Mhm.
as the co-chair of this liaison of coalition for the national network of coalition of diabetes for Asian Americans, Pacific Islanders, and Native Hawaiians.
And, I have so many questions. So, thinking back, I mean, before we get into the specifics, so there's a lot there to unpack, including how research and the inclusion of uh, different populations and research so we fully understand how conditions manifest themselves and the complications differently, perhaps. That's an important topic that we need to come back to. And then other areas about you've developed and as you alluded to, participated in many programs for to deliver culturally competent care, and I'd love to talk about the impacts of that as a specific intentional approach to how we care for patients. But even before we get there, I would just love as a expert in the diagnosis, treatment, and complications of diabetes. Obviously, you described a very impactful finding on the causes of retinopathy and diabetes. But from a treatment standpoint, how have you any general observations in 40 plus years of diabetes care that you get really most excited about and how we've evolved in the care for diabetes, thinking about your dad back, in the 70s?
Well, sure. There are a great deal of improvement and success really treatment. I'm not sure about prevention, but treatment of people with both type 1 and type 2 diabetes. So certainly type 1 is used to be called juvenile onset diabetes. And we have know so much about it now, and all the incredible advances on devices or even artificial pancreas now for people with type 1 diabetes. On top of that, we have the just approved new treatment to delay or prolong the remission with type 1 diabetes if you just developed it within a year or so. So, and then the really ongoing, I think in the fairly near future of even transplanting uh, beta cell derived from stem cell is
Right.
going to be a reality. The progress for type 1 is really moving along. For type 2 is just unbelievable in the last 10 years. We used to only have two classes of drugs. Now we have six different type of
Right.
oral drugs. And obviously we have the GLP agonists and SGLT2 inhibitors that could lower weight and protect the kidneys, protect the heart. So there's so many a variety of treatment that for people with diabetes, you could reverse type 2 as well. So I think if you have either type of diabetes, the hope is really good to go to remission, certainly control your
Right.
diabetes and treatment of many of the complications.
I think this is probably too long for our podcast today, but maybe we'll have to have you come back to talk about the impacts of GLP-1s, not only on the in the treatment and the comorbidities, but then all the just today actually was a better headline
Yeah.
about how it'll bankrupt the Medicare system, and so it's very
Yes.
complicated discourse right now on the role of GLPs because they have so many benefits while at the same time
Right.
major costs. So it's a longer than we have time for today. But maybe before we get into the specifics, also, would if you could talk a little bit about why Joslin. So, I imagine as a early career researcher and clinician, you had, I'm sure many choices, and I know Joslin has a long reputation. Tell me about that, about the what you're a part of here at the Joslin.
Well, sure. I think when I was a young researcher and endocrinologist, I think selecting uh, to come to Boston and being part of Joslin was not too difficult. Uh, First of all, why do we select the place we go to? We obviously think it's going to be exciting and fulfill what we want to do, and then allow us to have success in what we want to achieve. So I think both uh, Boston, Joslin, being part of Harvard, fulfill all those criteria because it's not a bad city to live in. It's very, very exciting. So be interested in diabetes and metabolism. Certainly the Harvard environment is really suits that. And Joslin has really the three components that allow it to really flourish would be it has a great clinic, great reputation. It has a basic laboratory and reputation of excellence in clinical research. So that was uh, the major reason. In addition, when I was coming up here, Dr. Ron Kang was just agreed to move from NIH to come here as a new research director.
Hmm.
And since his reputation was already internationally well known, and so that allowed recruitment of a whole new crop of junior investigator to really um, create something totally new again for Joslin from research point of view. So those are the major reasons.
Yeah. Well, I know everyone's very grateful for what you have done and continue to do. But thinking now about some of the things you mentioned earlier, it, you know, I'm first of all, I would like to ask, you were doing bench research for a long time, but it sounds like the last decade or so now feels like at least having some part of your time be thinking about health services and how we deliver care in our Asian communities here in Boston, I'm going to guess also how that applies elsewhere. How is that as a researcher? Both, I mean, the clinician side, but more specifically as a researcher, how has that shift been for you, uh, and how has it been different or challenges or
Well, well, I've learned a lot. As you said, for 20 years or so, I was mainly a basic wet lab, work with culture cells and mice, occasionally human tissues.
right?
So who really don't talk back. But as a clinical, as now I run the Asian clinic at Joslin. I really the only Asian American diabetes clinic in the east of Mississippi that I have learned a lot
Yeah,
to. the differences on different community. I mean, Asian Americans, not just one community. It's
Right.
like 20 some different communities. So I learned to really to interact with the various communities. I learned uh, how to read a clinical journal. and, we, as a researcher, obviously, I want to understand why something works, something doesn't work, and how
Right.
are we doing outcome, as you said.
Yes.
So instead of just running an Asian clinic, we always measure our outcome and how are we doing, and and then even we have a couple of other arms. One is education materials, as you mentioned earlier, that the disparity in before 2000 was really terrible in that way of education material. All the Asian American education material direct translation. And I told American Diabetes Association at that time, your material is useless because
Right.
you're talking about cheese, bread, and really turn out even the second, third generation of Asian American still eat 50% of their diet from the country of their origin. So,
Right.
so
Supply.
for the Chinese American, we don't eat that much bread for breakfast. We don't
Right.
eat bagels. We so so we had to really re-innovate all the new materials, which we have done that here and through the national network, and finally convinced CDC to do that. Still
Hmm.
haven't convinced NIH to do too much, but so we have made progress. Again, we increase awareness because we had to learn about that. So I didn't even know other people did not know about, the providers did not know that Asians have high rate of diabetes.
Right.
The Asian American don't even know that because they said we're not overweight. So
Right. Right.
why do we even ask,
They
right?
don't. They don't
So
fit the
when we
stereotype.
got
Yeah.
the data from the NHANES, it's not surprising. Well, surprised to the NHANES people that the Asian American had the highest rate of undiagnosed of diabetes. But to us, they said, well, it's not surprising because nobody knew about it, right?
Right. 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 Do we know
So
why that is?
I'm sorry.
Do we know why that is yet?
No, we don't. That's the really the next part is uh having now increased awareness, we have improved diagnosis, and actually we're having a summit tomorrow, being the Asian American Month of Asian American care providers of Eastern Massachusetts on how to take care of patients
Yeah.
because of two problems. One is now we have increased awareness. I said, fine, we have increased awareness. We have all these patients, South Cove, which is Chinatown in Boston, for some of
Right.
your listener may not know, says, great, now we have diagnosed like 8,000 people with diabetes.
Oh.
What we gonna do?
Yeah. Yeah.
So that's one. The second question you're asking, a very important question, is why are there so much diabetes in Asian Americans? And not just again, we really need to disaggregate the South Asians, the Filipino Americans, Southeast Asian Americans, Vietnamese seem to have very, very high rate, even higher than the Hispanic and the Black Americans
Hmm.
at very low body weight. We don't know. The answer to your question is we don't know why, and there's very, very little study in the U.S. On it. So we are trying to encourage NIH to sponsor more studies because so very little study on it. I mean, we got the first study supported by NIH to study something called continuous glucose monitor
Right.
in diabetes. Turn out, there's been millions of people using it in the US,
Right.
hundreds, thousands of studies. There hadn't been a single study in Asian American on the use
Wow.
of CGM. So,
Wow.
so this is what I'm talking about, the lack of information. So one is information of what do we do now with all these referrals.
Right.
Then second is why are there so much diabetes? And there's a new problem coming up. That's one topic tomorrow we're going to talk about. Again, this one just came up the last 5 to 6 years. Gestational diabetes in South Asians and um, in Filipino American and Chinese American women is skyrocketing. And I think we really need to take a look at it. So it sounds a little bit odd, but I'm really excited about the EPIC, which actually is going to have the BILH system that
Right.
we can actually hopefully starting to look at this question from, system-wide level. So that's going to be, I think, very, very exciting.
Yeah, for those listening, we are going live here at BLH with our unified medical record system here in 2 weeks, I think. So it'll be exciting times for sure. If you think about, well, I mean, actually, I was going to talk a little bit, which I do want to come back to about in the now what, and once you've assessed everyone and how we deliver care and the effectiveness of what you've created of culturally competent care,
Right.
in your clinic. But before we go there, I don't want to lose a research train. What is it going to take, do you think, for the funders for all the major research in the U.S.? Because we hear this a lot in conversation of, it's often white males in a lot of sort of health services and other research, frankly. And I know the industry is trying to evolve, certainly pharma's trying to evolve, but it still seems that we're lacking on inclusion of more diverse populations in research, and it has real clinical implications to your point. What do you think it will take?
Well, I think we take really a considered and targeted effort. I think that just too many questions if we trying to target them all. And there are some really, really important and specific questions. Again, uh, one question you just asked, we really need to target 2 or 3 of the most prevalent Asian American populations, like East Asians and Southeast Asian and South Asians, and really carefully um, characterize the groups as to why they develop diabetes. And that has just started, I think, and I just finally are funding something called the Masala study, which is targeting South Asians. And they are going to look at 10,000 Asian Americans as a group for a variety, mainly cardiovascular disease. But I think this is the first step. But again, I think for diabetes point of view, we really need to understand why some are developing uh, diabetes, type
Hmm.
2 specifically, uh, and and that really need not so much EPI study rather than uh, really a well characterized small cohort, very small, and do detailed physiological analysis, which they have not funded any of that.
Well, we'll keep pushing. Sounds like.
Right.
Um, on the delivery of care, we discuss often culturally competent care, and the data in general, from what I've seen, is pretty overwhelming. That if you provide culturally competent care, is defined by various mechanisms. You have clinicians that look like the patient that share a similar language or culture or belief system as the patients. That often that can lead to better outcomes. I think there's certainly general understanding and data to support that. And it feels like to me like a dose. If you could dose up culturally competent care and had a similar effectiveness relative to regular care, gosh, we would be investing a lot more in that. It feels like because the effectiveness feels profound. I'm going to guess that you have found that to be true in the clinic that you've created within the Joslin. But I wonder if there's just in direct observation what you have seen since you have started this clinic and in terms of outcomes or even anecdotes or uh, you know uh, engagement from patients or anything that you've observed since starting this clinic relative to the way it was in the past, any improvements?
Yeah, so I think it's important very important question. We do all this work and raise money to support it and so forth. What have we done, concretely? So as a researcher, I always want to know outcomes. So we actually have published data and
I
on
figured.
people who refer to Joslin and and what happens 1 year. Now we are hopefully going to publish soon the 5 year data and also the data pre and post COVID as well. So from the first paper we published, what we found, which is not surprising, that the people referred to us in the Asian clinic and mainly from community health centers because they really don't have the time for really difficult to care people with diabetes, right? So the A1C is 9, 10, 11,
Yeah.
sometimes 14, 15. Then they send their patients to me. I always
Right.
tell people my first three patients, I thought maybe the lab was error because one had a A1C of 14, one had a 16.
All in a
And
row.
I'm sorry.
All in a row. You were seeing all of them.
Yeah, in a row, and I thought maybe the lab printed wrong, and but they were right. So what we found was that compared to the Caucasian referral to Joslin versus the Asian American referral, the A1C is easily 1% above versus 9.5 versus 8.5,
Mhm.
and on top of that, their socioeconomic level was much lower. We have
Mhm.
80% Medicaid patients
Mhm.
versus 10 to 12% at
Right.
Joslin. And their education level was elementary school rather than college or level. So
Yeah.
we said, well, I go to this disparity conferences, and every year I hear that the people who are not care well are lower less education and don't have as much socioeconomic resources. So I said, well, they're always going to be in the world for people who are not as well. That means we're never going to overcome this
Right.
disparity, right? So
Right.
so I think we can. So we use the resources we had to translate the material. We have the full our providers and even coordinators and all speak the languages of most of our Asian American. And so from that, what we found is after 1 year, all the clinical parameter, which we call ABC, hemoglobin A1C, blood pressure, cholesterol,
Mhm.
were exactly the same as to the Caucasian population. And so our show no show rate is actually the lowest of
Wow.
all the
Wow.
groups because even though they don't have and their socioeconomic level and education did not change
You're not
after
right.
one
Exactly.
year.
Exactly. But
So
yeah.
we're very happy about that we actually have done something. As I mentioned earlier, now the problem is, uh, you know, we we are limited resource.
Yeah. How do you
So
scale?
no way we could see thousands and thousands of patients, right?
Right.
So we
Right.
have to be able to export what we have done here into the community health center. And we
Right.
work with CDC to do that. And it's actually very difficult because as well, better than I do, that these community health centers providers are totally pushed to the end. So how are they going to find another 15, 20
Right.
minutes per patient, right?
Right. And they may not have the other resources in terms of the education materials in the right language or staff. Most importantly, probably staff that can
Right,
speak the language is a very precious resource.
right.
Uh, I know you were working on having clinical pharmacists as partners in the community when we spoke now a few months ago. Maybe you can mention a little bit about that and how that's going.
Well, that's critical because uh, even though we have all these wonderful drugs, they're getting more complex.
Yeah.
And,
Yeah.
the average number of medication my patients in the Asian clinic now is like 7 to 8, right? It's not just
Wow.
diabetes. They have
Yeah, yeah.
other problems, blood pressure problem, heart problem, kidney problems. So to go through and all of them, and easily they're on 3 or 4 diabetes medication, and they are also conflict. So it's really critical that we work with our pharmacists. Uh, so the good and the bad the difficulty is 80% of them are immigrants and they don't speak language
Mhm.
English that well. But to take advantage of that, they all go to very few pharmacies because they can only go to pharmacy when they speak
Or
English.
they speak
They
a
only
language.
speak
Yeah.
the language. So we could work with them, like the Taitong Pharmacy in Chinatown. There's a CVS in Chinatown actually have people who could speak Cantonese and Mandarin.
Wow.
So the good news is we can work with them. So now we just began to work with the BIDMC pharmacy. Hopefully, we could work with them to have some language ability to have our patient to do that. But one nice thing about BIDMC is they actually mailed the drug. So our people in our clinic, Asian clinic, could actually interact with BIDMC pharmacy and then could avoid at least that
Right.
step. So
Other
this
stuff.
is really critical. I'm glad you brought that up.
Well, no, it's there's obviously a lot more work to do, but I think it's pretty amazing how you've tried to use the community resources and our internal resources in combination to try to scale this, but really impactful. Congratulations to that. As we're closing, I wonder if you could end a bit talking about what are you most hopeful for over the next few years in the care of your patients with diabetes. What are you most excited about?
Yeah, I think uh, I'm very excited about multiple things. So people with type 1 diabetes, uh, I think we're going to have really new treatments that could get to the root, either prevention of type 1 or actually restoring beta cell function, not just by transplant, by
Right.
actually regrowing the beta cell that almost all people
Totally.
with type 1 diabetes have. Actually, we actually were responsible to discover that a few years ago.
Mm.
Again, that also came from Joslin. This is called the MEDLA study. People who, rare group people who live 50 to now someone close to 90 years of type 1 diabetes,
Wow.
yet they don't have any of the complications. So we could develop why they're protected against the complication, right? So I think we could restore function, we could protect against complications. So for the type 2, again, as I mentioned earlier, there are all these new treatment. Again, can you revitalize the beta cell, regrow them, and weight loss, as you mentioned, it is expensive. You could decrease obesity, but I don't lose hope there. I think even from healthcare point of view, because many companies are developing drugs, there's going to be competition. So pharma not going to like this, but you could produce these medications at maybe 5 to 10% of what they're charging. So
Yeah.
hopefully people like you, Rob, who have important power on the national policy point of view, could really get the cost down. So really, it's possible. There's what I don't know whether it's probable or not, but theoretically, it's absolutely possible to lower the cost so it doesn't have to bankrupt the country and
Yeah.
reduce diabetes and prevention. I think prevention is really key,
Yeah.
and there are so many ways that has already been proven, let me say proven, that
Mhm.
we could prevent 80% of people with diabetes. So that has not really been focused too much, and
Right.
we didn't talk about too much today, but there are proven ways to do that, and we are working on that.
Sounds like the subject of another podcast, George, here at some point.
Right.
I want to thank you just on behalf of BLH, but also for your on behalf of your patients, that your contributions that you're still contributing, but everything you've done so far for the care of patients with diabetes is pretty remarkable. And thanks for taking the time today.
Sure, and thank you for giving me the forum to provide the information.
Absolutely. Well, if folks have ideas for future podcasts, please leave comments on social media and please don't forget to rate us on your favorite podcast app. Thanks for listening.